on this very important panel on one of the biggest crises I think that's facing our nation today is the opioid epidemic. My name is Greg GLOD. I'm the manager for state initiatives at Right on Crime. We are affiliated with the Texas Public Policy Foundation, which is a conservative think tank based in Austin, Texas. Right on Crime's primary focus is to research and advocate for criminal justice reform that will increase public safety, empower victims, and to restore the lives of those impacted by the criminal justice system. More and more people each year are dying of opioid overdose. According to the CDC, of the 52,404 drug overdose deaths in 2015, 60% of those involved opioid abuse. Half of that was from legal drugs that are prescribed by doctors, and the other half were from illicit drugs such as heroin and now the more ever prevalent fentanyl. With a higher prevalence of cheaper, more powerful opioids such as fentanyl, those numbers are just continue to rise in 2016, 2017. I believe we actually have some recent data from New York showing that is continuing to rise for 16. I guess we could probably put on the back of the table over there. Not surprisingly, with hundreds dying each day, lawmakers, law enforcement agencies, healthcare providers, as well as community organizers have attempted a variety of responses with mixed results. Also, not surprisingly, many of these responses from law enforcement and lawmakers have been an increased punishment for those who are possessing or selling opioids, bringing back bad memories to the failed responses of the crack cocaine epidemic in the late 80s and early 90s. Today we're going to talk about the good, the bad, the ugly across the country from all different levels, and we have a wonderful panel today of people that deal with state, federal, local, down to the person policy here. So we're going to get all to it. First person I want to introduce to my right here is Lorenzo Jones. He's the co-founder and co-executive director at the Katal Center for Health, Equity, and Justice. For nearly 15 years, Jones has served as strategic advisor and consultant to criminal justice and policy reform organizers and campaigns around the country. From 2005 to 2016, Jones served as the executive director of A Better Way Foundation, a Connecticut-based organization that used advocacy and organizing to build power in urban, suburban, and rural communities most affected by the drug war and inequitable access to resources. In 2013, Jones was honored with an award by the Drug Policy Alliance in recognition of his efforts to make democracy work in drug law and policy reform. To the other right is Loren KRISAI. Loren KRISAI is the director of criminal justice reform at Reason Foundation, a national libertarian nonprofit organization that publishes Reason Magazine and Reason TV. Her work focuses on a variety of criminal justice policy issues, including sentencing reform, pretrial reform, and drug policy, particularly at the state level. Her work has been cited in many local and state publications, the Washington Post and the New York Times. She also wanted to mention that she graduated from the Ohio State University, and coming from a Penn State grad, I don't know why you'd ever want to admit that, but
it's the Ohio State University.
The Ohio State, yeah. We'll see you in a couple weeks. Yeah. Mark O'Brien is the policy director at Addiction Policy Forum and a recognized expert on criminal justice and addiction, with over 8 years of experience advocating for and implementing smart policies and practices in these areas. Prior to joining Addiction Policy Forum, Mark served as Baltimore City's director of opioid overdose prevention and treatment, managing a high-profile overdose response cited as a model by President Barack Obama, U.S. Surgeon General Vivek Murthy, and U.S. Director of National Drug Control Policy, Michael Botticelli. He was a senior criminal justice policy associate and acting director of communications at Legal Action Center. Dr. Alex BENNETT is a principal investigator and deputy director of NDRI's Center for Community and Health Disparity Research. Dr. Bennett's current work focuses on overdose prevention and response, and his current projects include a study of opioid use, misuse, and overdose risk among veterans that will help determine ecological, structural, and psychosocial aspects of opioid use and overdose risk. Dr. Bennett earned a PhD in applied history and policy from Carnegie Mellon University and an MPA in public policy from the University of Pittsburgh. And with that, there are our panelists. Loren, why don't we start at, I guess, the top here? And that'll be you from a policy standpoint, at the very least. Battling the opioid epidemic, as I see it, has been dealt with in a variety of different ways based upon the jurisdiction, based upon what level that we're talking about, local, state, federal. Let's focus for a moment on kind of some of the bad policies that you have seen based upon your research and going across the country.
Yeah, so I'm happy to kick things off with some negative, pessimistic view. That's usually the role that I fill in these panels. Kidding, but So I'm just going to talk about, I think, some bad responses to the heroin, opioid, fentanyl epidemic. I think that we're seeing at the state level. Just to contrast that with this sort of, the way that it's been covered in the news, I think, is that we have this new approach to heroin that is a compassionate response. And I think we're seeing that more at a local level in certain jurisdictions, especially with, overdoses and users. But I think that on the whole, a number of states have passed really, just kind of the same old legislation, tough on crime, cracking down on opioid abuse that has, cast too wide of a net, even, encompassing possession offenses and things like that. So I just have like a few examples to kind of illustrate what I'm talking about. So we'll start with Louisiana. In 2014, they actually established a 10-year mandatory minimum sentence for any heroin offense, actually, including possession. And there's no threshold or anything like that. So you can possess, minuscule amount of opioids, heroin, fentanyl, and things like that, and you are subject to a 10-year mandatory minimum sentence. That was in 2014. And that's probably the worst law that I've seen passed in recent years. And Louisiana always at the top of the list with that kind of stuff. And even in the reform package that they passed in 2017, Louisiana was, celebrated for passing this comprehensive reform package, trying to change their title of highest incarcerator in the world. But a part of that package, they imposed a 1-year mandatory minimum sentence for prescription opioid offenses. I don't have written down if that was sale or possession, which is my fault. But something to do with prescription opioids, they introduced a new mandatory minimum sentence, despite recognizing that they need to start to scale down some of these tough sentences for drug offenses. Alabama, they increased, this was in 2012, possession of a controlled substance with intent to distribute. They increased the class felony. Illinois, they passed a new, they enhanced their sentences for illegally obtaining a prescription. While Governor Pence was governor of Indiana, and during which, I just like to note this, just because I'm petty, during which time he attended a CKI criminal justice reform event and was a keynote speaker. I was in attendance talking about, how we need to approach drug use, especially in context of the opioid epidemic. We need to, have a different approach. He reinstated a 10-year mandatory minimum for heroin and other trafficking offenses if a person has prior trafficking offense. And that term trafficking has also kind of expanded its definition. If you think of trafficking as, and I'm sure I'm preaching to the choir to a lot of you in this room, but if you think of trafficking, the average person thinks of people who are bringing boatloads of cocaine, the 80s and, Miami and, all these big drug lords. But the term trafficking has expanded so much over the years that now it ensnares a lot of low-level, personal possession offenses. And that's what we're starting to see here, too. A number of different states have lowered the threshold necessary to trigger a drug trafficking offense. Kentucky in 2017, they increased penalties for trafficking heroin below 2 grams, or they lowered the threshold to 2 grams of necessary to trigger a trafficking offense. West Virginia did as well. It's crazy. I just have like an entire list of different states that have increased punishments for low-level offenses.
And a lot of those states, those are the worst rates of addiction and overdose, and they have continued to rise even after these bills have been passed.
Right. And I think that another thing that when we're talking about overdoses, I think that we've seen a number of states that have either created new laws allowing for people to be prosecuted for manslaughter or homicide or other murder-related offenses for distributing or selling heroin or other opioids to a person who later overdoses and dies. Or they're dusting off these statutes that allow for these drug death-related prosecutions. 5 states between 2011 and 2017 introduced or passed laws that allow for these various murder or homicide charges for selling to someone who overdoses and dies, which is extremely problematic, which I'll probably talk about later. But basically, I say all this I note all these examples just to say that the compassionate response to heroin is we're not really seeing that at the state level, especially with in regards to possession with intent to distribute, sale, other things like that. As far as how we're treating addicts, I still haven't seen too much evidence, at least in the states that I work in, by the way. They're kind of the red states, so I don't have as many good examples off the top of my head of how we treat people who are addicted to these drugs. But we're seeing a lot of people getting caught for personal possession offenses, but charged with trafficking and other things like that. And so that compassionate response, I'm still waiting to see how that's going to play out at the state level. So that's just my experience, I think, on the policy side of the bad. So I hope that we have some good examples that can kind of lift us up from my pessimistic viewpoint.
And something you touched on, I think it's important, is how these narratives of what a user is and what an addict is and what a trafficker is, and where do they come from? How are they framed? How deep into our criminal justice system have they been targeted? And Alex, you did a tremendous amount of work on this, and a lot of your research dated back to the 50s and 60s on how these terms were kind of defined. And can you touch on that and how they're defined and how they carry policy throughout?
If you look at a historian, David Courtwright, who really has written one of the good books on this, if you think about the dominant framing of the addict and how that framing, not the use itself, but the framing through the media tends to shift. And as that shifts, we tend to embrace more punitive or therapeutic policies. So in a sense, the criminal, the addict, people of color are often treated as criminals. People who are not, who are better to do, are often treated as patients. And this, if you think about the 1950s, you had mandatory minimums. You had the Boggs Act and the Narcotics Control Act. Both of these were associated with an increase in heroin use among inner-city African Americans. By the 70s, that expanded. So we started to embrace a treatment and punishment dynamic, right? So primarily we would treat MAT, buprenorphine, not at that point, those better to do. And we would punish, and that's when you start to see the buildup of sort of the prison industrial complex. With sort of the disproportionate targeting of minorities. Now, I'm not saying we know that in terms of data, not that drug use is concentrated in communities of color, but oftentimes use of public space and things like that result in differential pickup by these peoples of color, right? And so with the post-World War II, during World War II, there's very little heroin, big surge in the inner cities. And all of a sudden, boom, we have mandatory minimums. Boggs Act, 1951, Narcotics Control Act, 1956. And you had students actually advocating for life in prison for people who sold to a minor. A lot of my research was on the 1950s, looking at California, and so you had petitions to the mayor, the governor, parents saying, put these dealers to death, okay? And you also had other drugs floating around there. You had, then it was, now we have Percocet, Vicodin there. You had the barbiturates primarily. And so you had a lot of mixing. Indeed, in my dissertation, there was a lot of overdose. The overdose there was primarily Nebutal, Seconal, and combined oftentimes with alcohol. And so I think we've seen this. And again, there's no direct relation, but there's, at least the way the frame, the framing in the media, we tend to see, and as Lauren points out, this is not across the states, right? There's a lot of difference, but we tend to see more of a back and forth between a therapeutic benign versus a more criminal punitive approach, supply demand reduction, and one of the things I'll talk more about as we move on is sort of this concept of harm reduction, right? Reduce the harms. Think about the community, think about the individual. We so often think about just the drug in this sense of pharmacological determinism, but there's so many things that are going on in people's lives, right? There are housing, homelessness, mental health challenges, right? So all of these things need to be addressed, I think. But I'll talk about that more. So just a little about the history.
Certainly, yeah. No, I think that's important to kind of see where these narratives are framed. let's talk about a little bit of the good. I think at the state level, at the tippy top, we're seeing, as Lauren said, a lot of the failed responses from the 80s and 90s, but there is a lot of good coming at the local level. And Mark, you managed an opioid response that, got pretty good high praise. I'd say when the president is giving you some props, that's not a bad day at the office. So can you talk a little bit about...
Props went to my boss.
Yeah. Which happens quite a bit. We'll give you praise a little bit now. It's being live streamed, so yeah. Take the credit now. Hope he's not watching. Yeah. Can you elaborate on this a little bit, and how could this be reproduced in other jurisdictions, and what can lawmakers do? And touch on that, please.
Yeah. So, and I should say I left the Baltimore City Health Department about a week and a half ago and joined Addiction Policy Forum, and it's kind of amazing that the new stuff I'm trying to shove into my brain is like already slowly forcing out the stuff from just a week and a half ago. So I'm going to do my best. In Baltimore, we've had a heroin problem for decades. So I think unlike a lot of jurisdictions, we've been grappling with opioid misuse and addiction for quite a long time. We're very fortunate in the city to have a health commissioner, Dr. Wen, who's very, she's both brilliant and highly motivated to tackle this epidemic. And so what we did in the city was implement what we called our three-pronged strategy for responding to opioids. And the first prong is really, knowing that our city, and I think probably similar to a lot of other jurisdictions, it's a city of neighborhoods where people are really close-knit, they know each other, they look out for each other. And so our first pillar for this strategy was to prepare everybody that we could in the city to recognize an overdose and respond with the overdose reversal medication, naloxone. Over about 2.5 years, we trained 25,000 people in the city to administer naloxone. We gave out 42,000 doses of naloxone, which is enough to give one to every single person in a sold-out Camden Yards. That's our baseball stadium for those of you who are not AL East people. And most importantly, so before I was in Baltimore, I was doing public policy work for Legal Action Center in DC. My background is in law for about a decade, and went to Baltimore both because it's home and it was this crisis is something that I wanted to be a part of helping to respond to, but also because I had been doing a lot of advocacy and policy work for a long time, but didn't really have that practical nuts and bolts experience of being on the ground and trying to really implement change. And what I learned as a public health person was that we really spend a lot of time in public health thinking about data, looking at data. It's very important to know if what you're doing is working, what the problem is, all these things. But it also can kind of take the heart out of what you're trying to do. And so to me, the really most important thing about what we did with the naloxone training was that because of that, everyday people in our community were able to save over 1,000 lives in those 2 years. And this is in addition to our first responders every single day reversing dozens of overdoses. These are just regular folks who were able to help friends, family members, neighbors. And the other thing is, again, thinking about the numbers and knowing that 100 people a day are dying in this country from opioid overdose. In Baltimore, it's about 2 people a day, and 700 people a year. That again, that we're not just talking about numbers. We're talking about people's mothers and fathers. We're talking about our neighbors, our friends, our children, brothers and sisters, and it's the loss of life that's really on an unimaginable scale with this. But it's also the family and friends who are left behind, and we're talking about 100 families every day with a newly empty seat at the dinner table. And overdose reversal is an important part of the solution, but it's only one part. It's really addressing the absolutely most acute sign of this epidemic. And so the second prong of our strategy was really thinking about how we could expand access to addiction treatment. And I think when you talk about expanding access to addiction treatment, you have to talk about a lot of different things. It's the capacity of the system, the networks that are in place to coordinate care for people, access points, health insurance coverage. And I think there are some very good models out there. Vermont's hub and spokes model for buprenorphine treatment is something that we were in the process of replicating in Baltimore. Also just thinking about like practical things, like we had 4 phone lines in the city if you wanted crisis services, mental health services, substance use disorder treatment, whatever it was. There were all these different hotlines, and like who knows all the hotline numbers, right? So just practical things of getting together with some partners and saying, how can we just tie this all together so there's one phone number and it's available 24/7, and you have a clinician you can talk to and get navigated through the system that way. And then the third prong is and these are almost kind of in the reverse that Addiction Policy Forum talks about them, which is another way I've got to wrap my brain around this is the prevention piece of this, which is around educating people who use drugs, people who are at risk of becoming dependent on drugs, their family members, but also the providers. One thing that we were really big on in Baltimore was convening our emergency department physicians, primary care providers, and getting together and figuring out how we can reduce the flow of prescription drugs on our street. And then I'd say, I think I gave you a lot of what we did. I think the big thing that I took away from this work was that because this epidemic is so large and it really does affect so many different systems, was that there really is no sector that's going to do this alone. And we had a task force in Baltimore that included 23 city agencies, from the police and fire department and health department all the way to the library and the rec centers, all coming together and figuring out how they can be a part of the solution.
And nothing that you said seemed to need approval from one council member, one lawmaker. It just seems like it's local buy-in and community, everyone coming
That's
together.
exactly right, and some funding. Yep.
Yeah, and it doesn't.
That's right.
How much funding are we talking about to kind of get this
So
off the ground?
I'd say the intervention that I described that is the most expensive for the health department, because some of the treatment services can be reimbursed by Medicaid and things like that. The naloxone distribution can be prohibitively expensive. We were able to pull that together by relying on private funds, state funds, federal funds, donations from pharmaceutical companies. But it can be expensive, but I also think that you can have a huge impact without doing it on the scale that we were doing
Right.
it on, by being smart about how you target distribution of the medication and figuring out other ways to get it in people's hands.
Distribution medication is definitely something I want to touch on, particularly with Alex, because that's something that he's talking about. I'd first like to get to Lorenzo, because community buy-in is something that not too many people that are better than community buy-in than you, and getting everyone together. And so someone who's worked firsthand with communities that have been hit the hardest by drug epidemics from 70s, 80s, 90s, today, what are the biggest things that are hitting these communities? What are the biggest barriers, and what have you seen has been successful from, just from a local buy-in from this? I mean, when we see the numbers, most people get their illicit drugs or their opioids from friends and family. And so, that's a troubling statistic, either by theft or just by, being complicit in the whole thing and apathetic and trying to help someone by giving them these medications. So what have you seen at the community level that is hurting everyone the hardest, and what's been helping?
So, can you hear me? Is this on?
I think you're good, yeah.
All right. So, Lorenzo Jones, I am the co-founder and co-executive director of the Katal Center for Health, Equity, and Justice, formerly the executive director of the A Better Way Foundation in Connecticut. We facilitated the grassroots and the organizing strategy that built the public will for reform in Connecticut. We had a lot of help on the inside, but we did the heavy lifting of shifting the public will. That's why A Better Way was started. So let me just explain really quickly the LEAD program, just as a practical response. I don't know if you've heard about LEAD, Law Enforcement Assisted Diversion. I'm sure you probably have. Came out of Seattle with Lisa and them. It's spreading across the country. Katal was helping to build, we helped to build the LEAD National Support Bureau, which provides technical assistance to programs looking to do diversion and front-end diversion work inside of municipalities. We've brought to that relationship, and we feel like we're bringing to the table here a different, or I should say a more integral look at service delivery inside of municipalities as determined by the people who receive those services, not as determined by the city. So one of our major obstacles in developing public will for this actually has been attempting to develop relationships with the inside folks. So legislators, legislative staff, municipal, city council people who actually have a responsibility to be bureaucrats. They have a responsibility to kind of make the system work not necessarily make it work for people. That's what they do as good people. And so we do community organizing to build the political power to force them to do what we demand. That sounds confrontational. It sounds like there's a lot of friction, but really, if we approach this conversation as talking about addicts and poor people and marginalized people and destitute people and people who fit this, what we think in our back of our mind, the stigma of like people who need our help, which by default means these are people who can't help themselves, at least that we believe. And so as an organizer, we go into these communities and we build people's confidence in demanding what they believe. And then we partner them with people in other communities, suburban, rural, and we do the same. It's not just black and brown people in urban neighborhoods who have been marginalized by a system that's not first concerned about them. There's poor people in rural communities. When we went into places like Willimantic and started organizing around heroin use, not addiction, heroin use, people self-medicating, veterans. We went and we started working with families there and people dealing with that stuff. We found out that the issue wasn't necessarily programs. It was public transportation to programs. So our organizing wasn't about building programs in necessarily that space. Other people were doing that already. It was about getting people to the programs and getting resources that got people to those programs, like meeting those people's needs. And so we start with our organizing with the core principle of harm reduction, which is we meet people where they are without judgment. It is impossible to do that as a legislator. It's impossible to do that as a city council person. It's impossible to do that as a program staff person because your direction is coming from the top. It's coming from someplace other than you. And you ultimately are facilitating whatever and looking for the expectation from that neighborhood person. So we end up with advocacy around these issues being, based in like client-based advocacy. And so people who are part of programs that people run are asked to come and advocate for like the things that program needs. That's not building community or public will, right? The alternative to that would be to talk to those same people, but in their space, in their neighborhood, at their kitchen table, and have them build something that brings that system to them, not tells them that they have to continue to like acquiesce to that system. And so our most major problem has been recalibrating, excuse the expression, the relationship between directly impacted people in neighborhoods and people who, are in positions to make programmatic and systemic changes, right? That includes law enforcement. I'll stop here. But LEAD, for instance, prior to me going to a Better Way Foundation, I was a public safety organizer in Hartford, right? We did, culminating with the Hartford Community Court. And the Hartford Community Court, in theory, so I've been in meetings where white people said, you know what the most successful outcome of the Hartford Community Court is? There was absolutely no racial backlash for us building a court that primarily adjudicated cases with black and brown people for broken windows, quality of life crimes. That's incredible. How do we do that? How do we create a court to adjudicate cases that are predominantly poor, homeless, destitute, vulnerable, marginalized, black and brown people? And nobody said, hey, that's racist or that's wrong. Nobody. And they said that was a success. It's like the LEAD program is what, in my opinion, the community court said it was going to do. So we sold the community. I was the organizer on the ground in all the neighborhoods, moving the community court. The reason why there aren't rallies against it isn't because people in neighborhoods weren't asking those questions. It's because we were managing those questions inside their neighborhoods. Those questions didn't show up at the sanctions committee. They didn't show up at Judge Norco's table. By the time people got to that table with Judge Norco, by the time Judge Norco from the court got to that table, they were working in a partnership. And the reason why there wasn't some major backlash was because the court was responsible and responsive to the community that they claim to serve, not adjudicate cases from. And so this relationship, restructuring, recalibrating, rebuilding these relationships around public safety being based in public health and harm reduction, right? We feel like in Hartford, we're in a really good place. In Connecticut, we're in a really good place to actually do this stuff from the ground up. And we've got some existing partners inside the legislature, inside the governor's office, inside like these different programs who are interested in like actually making treatment versus incarceration like a real thing, right? And empowering police departments and local law enforcement municipalities to drive like a treatment versus incarceration agenda and building political will behind them for that.
And it works. I mean, the thing that when you go into a lawmaker's office, and I do predominantly do a lot of my work in Texas, and you go to these very conservative jurisdictions, and you show them the efficacy of these LEAD programs showing this is reducing recidivism, this is going to cost you less money down the line. We're getting a better return on investment on that, and that's what speaks to it. And to kudos to you, and he actually has the report on the Albany LEAD project, and we'll have some copies in the back if you'd like to take those as well. Kind of getting back to something that we were discussing, Mark, with your kind of three-pronged approach that you took, was this heroin, naloxone, opioid antagonist. In Maryland and New York, I know, and a lot of other states, this is easy to administer for a lot of varieties of population. But in a lot of different states, Texas, for example, only certain doctors, some nurse practitioners, things like that, they're the only people that can administer it. And by the time that you get someone into an ambulance, down to the hospital to administer this, it's probably too late. And so, Alex, I know this is something that you've worked a lot about, is kind of these barriers to treatment and to these types of drugs. So if you could elaborate on that a little bit.
Yeah, I think also it's sort of, I came to New York in 2010. And so prior to that, I worked about for a decade in Pennsylvania, which is a very different dynamic. It was at Prevention Point, Pittsburgh. And so late 90s, we were actually still underground, a lot of advocacy. We actually, coupled with research, we had 82% of our participants at a syringe exchange program were HCV positive. So we used that data, advocated, and they declared a public health state of emergency. We became legal, open 1 day a week to give out syringes, eventually naloxone. We were housed in the former juvenile justice detention center. So participants would come in, and they're like, oh, I used to be in jail here as a kid. So it gives you a sense of how drug users are treated, right, in some states. So I eventually, we still need a doctor prescription now in Pennsylvania. There is more widespread. There's pharmacy access. There's third-party prescribing post-1915 Act 138. But indeed, we have an article coming out, and so our research shows that when you give naloxone to people who are at greatest risk, i.e. the drug users, and we know that prices are going up, and a lot of communities cannot afford it, right? Baltimore seems to be able to do it. New York has a really great program. What's happening is some of the smaller community-based organizations, right, throughout the country can no longer afford the product or the naloxone, right? And so I come to New York, and I'm like blown away. I was like, wow, the city really supports harm reduction, a public health approach. And I was quite shocked, so I started volunteering with a lot of organizations. I'm currently working with New York harm reduction educators, and to me, it's quite remarkable. I mean, it's sort of a saturation project. You still need to get it first and foremost to the users. In our paper in Pittsburgh, 1995 to the implementation of Act 138, which allowed for third-party prescribing, we were virtually a 1-to-1 reversal ratio. Every kit we gave out, there was one reversal. Now, post-Act 138, it went to about 1 in 36 or so. Not saying that everyone needs first responders, everyone needs naloxone, but in tough economic times, I think it's very important to emphasize the users themselves, who are often in the situations to reverse an overdose. And this gets into the buddy system, right? coming out of, we're thinking about veterans and battle buddies, peers. But some of the things we're doing here with community outreach is we, a lot of our research revealed how veterans did not know about naloxone. They did not know about iatrogenic initiation and POs. They did not know. I have some quotes that all of a sudden they're like, "Oh, POs are like heroin," and so obviously, there's some travel, transport, things like that. I did a lot of work with the veterans in shelters. I would do, interviews with survivors of overdose to learn about that. A lot of interviews with ED, EMT, again, to try to figure out, sort of their perspectives on it. But luckily, eventually, NDRI, where I work primarily, and I teach nights here, we were established as an OOPP, an Opioid Overdose Prevention Program. And so now, even though I'm funded primarily through NIH, I felt it was an ethical imperative to have, if you have research participants at risk for opioids, to make sure they have naloxone. And we could not do that at first. I would talk to them, I'm like, oh, I had some, and shoot, sorry, And so actually halfway through our study, we got authorized, we registered as a program, an opioid overdose prevention program, and so now all of our researchers, participants, people who come in, they get naloxone. And so with that too, we also realize how veterans often relate to other veterans. And this, you have to think about identity here and identity politics, right? In terms of community outreach. Who can speak to who, right? What's the salesmanship like, right? And we got this idea that only veterans will speak to veterans. And so with the, wonderful help of the Department of Health here, who's been very, very supportive with all of our work, we ran a pilot veterans train the trainer program, where we trained 6 veterans, one-day training, and they became, in a sense, deputized, authorized, to go out and outreach and connect with other at-risk veterans, train them, and then give them naloxone. That worked out really well, and I think about 6 months we had about 450 engagements, meaning veterans engaged other veterans. Of those, 3/4 accepted naloxone, which is interesting because 1/4 did not, and that is something to think about, right? So it's about the framing. It's not about you, right? It's about, hey, maybe you'll run into, be in the situation someday to save grandma who had a cocktail and 3 opioids accidentally, right? Or, you'll be in that situation. So we learned a lot about engagement and framing and salesmanship, right? And how to talk about naloxone in a non-judgmental, stigmatizing way. And now we just started a 1-year longer extension of this program. And so we're essentially doing the same thing. They go out, we collect some data on tablets too, and we offer them all referrals to resources, how to access benefits, low threshold harm reduction services, HIV, HCV testing. The main thing, again here is sort of keeping people alive until they come to that point in life where they're not having a problematic relationship with either drugs or society, right? So.
I just wanted to say something to that point, right? To your question around obstacles and challenges, you would think that one of the initial challenges was NIMBY, not in my backyard, but what you're walking through, like the not in my backyard response was very initial and superficial. What killed that response from people was exactly what you're walking through, because we were able to get to people's kitchen tables and say, okay, like the experience you're having is not unique. As horrifying as it is, as grotesque as it is, it's not unique. And as we allow people to kind of walk them back off the ledge, so to speak, around like they didn't know what to do, we were able to find healthcare alternatives to meet them. Yeah.
Yeah, absolutely. And I think it's important because when I was talking to lawmakers in Texas, particularly about a bill that would expand who can prescribe and who can administer naloxone, I think there was this first hesitance of like, we're going to allow citizens to administer drugs. So can you just kind of, and Mark opine in here, I know you know a lot about it as well, what it actually is, what are the harmful side effects, if any, and kind of what does it do?
Can I grab it out of my bag?
Yeah, pop one out, yeah.
Right here too.
so I think even in a, Maryland is a pretty blue state. Baltimore, very blue city. But Maryland also is a state where there's a certain amount of kind of social conservatism, and so there was initially, when we started doing our syringe exchange program, there was a lot of pushback around the idea of doing harm reduction, that this was encouraging drug use, whatever.
Right.
And so the original syringe exchange program legislation in Maryland said there can be one syringe exchange program in the state, it can be in Baltimore City, and it can be run by the Baltimore City Health Department. So it was like, this is only going to be relegated to this very small part of the state. But I think as this epidemic has gotten larger, we see that there's kind of a change of heart, and that people have more familiarity with it. But then also getting to your question about kind of the safety and things like that, it's so easy to use, and I know, we have the one with an atomizer here. It's just, you pop the medication on the bottom of this needleless syringe, put a little foam tip called an atomizer on here, and you just do, Well, and I was going to say, so it really, I mean, anybody can use it. Like we would train people in just a couple minutes. There's a couple other formulations that are just as easy to use. Side effect wise, I mean, what I always tell people is this is so safe that the recommended dosage for my 2-year-old daughter, if she gets a hold of some of my medication somehow, would be the exact same as it is for me at over 200 pounds. The dose is the same because it's so safe. Our EMTs in Baltimore would use this as a diagnostic tool. So if someone has the signs of an overdose, they give them naloxone. If they come out of it, they were right, it's an overdose. If they don't, we try something else.
Right. It doesn't harm anyone if you're actually not going through.
That's exactly
it
right.
It just essentially rips off the.
Exactly, yeah. And I gave it to myself while training somebody, similar to just having it in my hand. I thought I had a sample from Adapt Pharma of the Narcan nasal spray, and I was mid-sentence telling people, it's so safe to use, I just gave it to myself and it's fine. And it was fine.
And just adding to that, it's interesting about the notion of, I interviewed a lot of EMTMS people who respond. And there's that myth out there that the person who overdoses is going to wake up swinging and punching and things like that. And that really hasn't been the story we've heard. It's sort of more, I mean, of course it can happen because you mess up someone's high, they're agitated. But one thing we're also finding more and more is that it's most overdoses are polydrugged, right? So involving, well now fentanyl, but involving benzo, Xanax, Valium, Klonopin, alcohol. So people, it would knock out the naloxone will wipe out the opioids, which could be good enough, right? But then the person can still be sort of a little bit like if they've taken like 5 mgs or 6 sticks of Xanax or something crazy like that, they'll still be like a little out of it. And so, it's an interesting thing, but it's, again, if you're not on opioids, you could just do it all day to yourself. It's a very benign drug. And it used to be a very cheap drug. In the early 2000s, we were getting it intramuscular for free. It's, I believe the New York City, these kits are about $90 intranasal. I believe the intramuscular is a little bit less. They have another brand, an auto-injector, which is like $500. Is it $500?
It's 4,500 is the
$4,500. So that gets you sense them.
You better be sure that they're ODing.
Yeah, well, that's what we're also
that
trying
cost,
to learn about is, if you have, a kit there, like, does it remind you not to be safe, right? It's an interesting thing. It's like, yes, let's, and let your friends know, right, that you have it, and not to be safe.
Yeah, I think people kind of get the notion that what is this, like methadone or something? That this could just be as addictive as the actual drug that you're trying to get someone out, but that's not the case with naloxone. What we're trying to do. Talking about barriers, let's get back to a little bit of the legislative response, because I know there's been some states, Lauren, that have looked at Good Samaritan laws where, say you're with someone is ODing, you want to call the cops, but now I'm around a bunch of heroin or fentanyl or illegal prescription drugs. I don't want to get in trouble myself. So some states have said, if someone is ODing, you can essentially, it's not a get out of jail free card, but it's a absolute defense to your prosecution or something like that. Can you touch on those and what states have done well in that, and kind of what that legislation looks like and what states are still kind of going the other way with it?
Yeah, so like Good Samaritan laws, you know, if somebody next to you is overdosing, you can call 911 and you won't be charged yourself. I will say, I'm going to stick to the negatives because that's what I'm best at. You know, there are a lot of states that have like some sort of a basic Good Samaritan law, as in call 911 and you'll be immune from prosecution for possession. But in Florida, for example, a state that I work a lot in, they have a Good Samaritan law just for possession. But recently there was this case where this girl, she was 18, she was with her boyfriend who was in his early 20s and another guy. They were all doing heroin together. Unbeknownst to them, it had some fentanyl in it. The girl, who didn't have as high of a tolerance as the guys that she was with, she overdosed. Her boyfriend called 911. They showed up. Unfortunately, she had already passed away at that point. And so he called 911, but he was slapped with a first-degree murder charge because he gave her the fentanyl, the heroin that was laced with fentanyl that resulted in her overdose death, despite the fact that he called 911, despite the fact that he was in a relationship with her and clearly didn't intend for her to be harmed in this way. He was still charged with that offense because in Florida, it doesn't matter if you sold the drug to somebody, you could have given it to somebody. You could have done the same drug as the person who overdosed and died. You could be a user yourself, and you can still be charged with distribution or sale, or even they really do have a first-degree murder charge for overdose deaths, which they just expanded this year to include fentanyl offenses. And so, you know, we can talk about Good Samaritan laws, but there are different, you know, kinds. And so I think that the best example of Good Samaritan law includes kind of immunity from prosecution for all sorts of offenses, and is just not limited to just possession. Because I think a lot of the times when state legislators are talking about this stuff, well, we don't want to. Their intentions are good, but what actually comes out in practice is you know, well, we don't want to prosecute this guy for possession if he gets it. Yeah, I mean, we get that, but you're still opening the doors for them to face other charges as well. So I think that's one of the things that we're seeing. A number of different states are starting to look at these Good Samaritan laws. I think that as a public policy response, you know, increasing the availability in naloxone is another thing that legislators are looking at. And those are two promising things that I see moving forward, even with conservatives who are looking at this stuff. And so I'm hopeful that, you know, as legislators start to educate themselves a little bit more about what these laws do, it's not condoning the use of heroin. It's not allowing people to, like, get out of jail free card or whatever. I mean, that still is like a mindset to them that these people need to be punished, even if they're addicts. I think that as they're starting to educate themselves a little bit more, they're starting to see that these are good public policy responses to this very real problem. So,
Oh, great. Something that we haven't touched on is prison. And there are a lot of people that are in prison, I think we'd all agree, that should not be there. It does not increase public safety, and the net of prison is definitely far too wide. There's a lot of people that need to be in prison. I think when you deal with individuals and you go, that guy needs to be behind bars, he's a threat to public safety, he's a habitual offender, these types of people. The treatment in prison right now, not many people are actually getting the proper treatment that they need once they get there. I think we can all agree that we want someone who's going in there that is better than when they came in, when they're coming out. So to the panel, can anyone kind of touch on what things they've seen potentially in prison that's working, and what are the barriers to that?
I think
you looked at me, so yeah.
Yeah, that's fine. I think gross generalization, because we're talking about systems that vary tremendously from state to state, and then when you're talking about jails, even county to county, that a huge barrier is just a lack of capacity for treatment. So people who are receiving treatment in the community and become incarcerated, treatment is interrupted, or the treatment modality that was working for them in the community is not available. We have a lot of correctional sites that don't have any kind of medication-assisted treatment, even though the science shows that medication-assisted treatment is the standard of care for opioid use disorder, or they don't provide the full range of medication. So they may have Vivitrol but not methadone, buprenorphine but not Vivitrol. So it's not having all of the medications available, not having good capacity, and then also not providing good transition planning and a handoff to care in the community when people go home.
I think, yeah, I'd add to that some. Essentially, when I worked in Pittsburgh, we were in the Allegheny County Jail after we developed the task force, and then we went into the pods, and we were able to do, good 2-hour overdose prevention trainings and link people to, services. There was a great warden there at the time who was in Baltimore, actually before, Calvin Lightfoot, and he really brought nonprofits in and things like that. They were not giving any MAT, things like that. At least they were teaching about risks and giving them naloxone now upon release, which I think people are trying to do more and more. And I can't speak to all that's happening in New York. I know they're doing a lot of really good stuff in the prisons here too. So maybe something else.
Yeah, excellent. Kind of getting back to what you were talking about, Lorenzo. You had something.
I want to say
Oh,
something.
sure, please, yeah.
Right, two things real quick. One, in Connecticut right now, there's an example. There's a program, I won't say the name of the program. There's a program in Connecticut right now that is supposed to be used to provide people treatment who test dirty, I guess, for their urines, right? And so you go to jail, you go to prison in Connecticut, you get out of prison in Connecticut, you go on probation or parole, and then you test a dirty urine or whatever happens, and then you get sent to, you don't get reprimanded back to custody, but you get sent back to, right, like pretty much coerced treatment because you're on probation, you're on paper. Guess where the treatment program is? It's at the same prison that that person just left. And then they go, we don't know why people are asking us, and why am I being reprimanded? Because I'm literally sitting in the same cell, probably, that I was sitting in when I was actually in corrections custody. And the state's not doing that to be mean. That's a resource thing. That's like chairs on the deck of the Titanic kind of situation. But you can imagine how like disenchanting and disheartening it is inside of communities where you got a person going, I just got out of jail, prison. I go home and I get dirty urine. My family don't know that I'm going to a program. My neighbors don't know. All they know is that I'm going back to prison. The guidance counselor, my kid's guidance counselor, my kid's teacher, the principal, the crossing guard, the store owner, the local police officer. All they know is that I'm back in the correctional facility. They don't know that I'm actually in the program and I'm not reprimanded.
Right. In Texas, there was a program essentially the same thing where if you had a dirty urine test or these technical violations while you're on parole and probation, it was called Safe P. Safe P was essentially just another prison just called something different. A lot of them were just essentially prisons that were repurposed for this. And then you look at the efficacy and you go, oh, their recidivism rates are just the same. I guess programs don't work. Well, bad programs don't work. Good programs do work. Right. There is a lot of good coming out in a lot of things. There's something called the HOPE program, which essentially has graduated sanctions. So if you have a dirty urine or you have a missed meeting, you know you're going to go to jail for the next 2 days. And you don't have to go through a whole court system. You don't have to sit in jail while you're waiting your probation revocation. It essentially keeps graduating. And that certainty and that swiftness of punishment is much more powerful and reduces recidivism much better than just a severe sanction, like you were talking about, just going back to prison. So they actually had a pilot program in Fort Worth, Texas as well on the HOPE program. And it looks like the numbers out of that are going to be very good. So there's a lot of different areas of the criminal justice system where we can trigger this and we don't get it at the forefront. There are a lot of back front solutions to that. And Lorenzo, I kind of want to talk to you a little bit more. Regardless of how many great programs there are, laws, anything, sometimes you just can't get to a person, particularly if they're not touching the criminal justice system and they're just out in the community, particularly in these rural communities. What can family, friends, neighbors do to kind of help someone that's dealing with addiction?
Oh, that's a great question, right? So,
I know.
Right. It's a great question because it's actually the realest part of the work. It's the most tangible, like obvious thing. Like these are like the obvious things. Like this is like my birthday was this past weekend, Saturday, the 7th. And this year, my sister, right, came up under what we now call the unintended consequences of the Clinton crime bill, right? That we know as genocide, right? As people who went through that, my family has been dismantled as a result of it. families that we're talking about have been dismantled as a result of the crime bill, welfare reform. In preparation for Barack Obama's election, they changed it from being racism to being unintended consequences. And for the record, if we want to reach people the way we have reached people, is we've done practical things with them that they could repeat in other places. So one, as part of our organizing strategy, we did what's called we created an exercise called incarceration community. We went into people's like suburban and rural homes, and we did an exercise in their home that talked about the impact of the drug war on local municipalities and communities. We can share that exercise with you all to try it. The second thing and most important thing we did was we went in and built bags. We put together, we partnered this past weekend with harm reductionists, and Katal does this across the country. We partner with harm reductionists about putting together things that people would need, but but the harm reduction field can't necessarily regularly afford. So we partnered with Greater Hartford Harm Reduction Coalition. They provided all the public health stuff, you can imagine, right? All the like harm reduction stuff. And we got a bunch of block club captains and community people to get together and put together care kits. We did 120 of them this weekend and left them with the Harm Reduction Coalition, who added condoms and all the harm reduction stuff. So it's a thing that now it's kind of like people are doing it on their own. So they're like practical activities. I'll stop here, but the thing I would suggest most is find something that people can physically do like regularly. Not give money, not go to the Capitol, not that stuff, but like the care packages, like if there's gonna be a community cleanup, if there's gonna be like a training around this, find ways you can bring in unlikely allies, because a lot of times we're preaching to the choir when we go talk to our folks. Bring in people who don't sound like you. So we brought in conservatives, black conservatives in Hartford, and they helped us kind of build our overdose campaign. So like, yeah.
Yeah, and some of the most fulfilling work that I've done is kind of reaching across the aisle.
right.
And, you know, we have a pretty, broad spectrum here, I think, on the political end. You know, Lauren comes from a much more libertarian view. I come from a much more conservative foundation. You come from, admittedly, you said progressive model, and we all kind of have been nodding our heads in agreement on pretty much everything that's been said. So we've done a little bit of poo-pooing on some conservative states, but there's a lot of good coming out of there, and a lot of the bills and a lot of the great reforms that have been coming out have been coming from the Texases and the Georgias and the Mississippis and the South Carolinas. Sometimes out of necessity, sometimes out of an existential crisis, but it is happening. So some of our greatest champions are, from the Tea Party right and, kind of reaching across that aisle. So it's been good. Do you have something to say about that? Yeah.
Well, I was just going to say something that I've noticed, from a policy perspective. Yes, there are a lot of conservative states that are starting to, take on this issue. A number of different states, passing different, comprehensive bills or small bills. Justice reinvestment has been an approach that a lot of states have taken on. But with this issue, it's so interesting. One of my points that I wanted to make is that a lot of these conservative states that are like, we are reforming our criminal justice system, they are so quickly dialing it back when it comes to the opioid epidemic. And sometimes it's the same people that sponsored the JRI legislation or the comprehensive bills who just a couple years ago got up there and were like, we are incarcerating too many people. Like, prison is for people we're scared of, not people we're mad at. We don't want to incarcerate drug offenders. We want alternatives to incarceration and treatment. These same people are getting up there a couple years later, or even maybe the very next year, and saying, we need to increase penalties for heroin possession, trafficking, whatever. I have just 3 examples off of my notes here. Just in 2011, Kentucky passed a justice reinvestment bill, and the hope reducing its prison population, diverting drug offenders from prison. But this year, and thankfully this bill did not pass, but this year a Republican senator introduced a bill that would have significantly increased penalties for individuals who sell any amount of heroin and fentanyl, elevating it to trafficking, so there's no threshold. Just a simple sale is now trafficking, or would have been under this bill. And it passed the Senate unanimously, and it eventually, a different fentanyl bill ended up being signed into law. But this is what he was saying when he proposed this legislation, okay? And by the way, he supported the Justice Reinvestment Bill. That's the only reason why I bring him up in particular. But his name is Senate President Stivers. He said that the new bill would probably cost, quote, in the tens of millions of dollars. And remember, one of the things that conservatives really like to advocate for when it comes to criminal justice is cost savings. But he says, it would probably cost in the tens of millions of dollars, but that, quote, it is worthwhile to send a message. It's time for this to stop at whatever level for whatever drug it may be. I mean, that kind of is dialing the rhetoric back a little bit, just because I think that there's such hysteria around this particular drug. A lot of people are dying and at an unprecedented level, and there's just this feeling always with legislators that they have to do something, and just their gut reaction is to just get tough on crime again, or I hate that term, but just get tough on whatever the perceived problem is, regardless of what the outcome is, even though they're able to recognize that mandatory minimums, prison, hasn't been effective with drug use in the past. For some reason, they're going back to it when it comes to heroin. In Alabama, Cam Ward, senator, in 2015, so this is even more recent than Kentucky's JRI bill in 2011, Alabama enacted justice reinvestment legislation in 2015. The justice reinvestment bill sponsor, Cam Ward, very vocal about the need to look at drug sentences and, who we're incarcerating for what. He spoke at a lot of conferences like this, or like conservative conferences on criminal justice reform. He is a strong advocate for criminal justice reform. But then this year he filed legislation. This also died, by the way, which is good news, I guess. But he filed legislation that would create mandatory minimums for trafficking in fentanyl. So small amounts, again, he lowered the threshold, and it would have created a mandatory minimum sentence of life without the possibility of parole for trafficking just 28 grams, which is not necessary. It's not an amount that an average user would have, but if you're talking, and if you're talking like mixtures of drugs, so like one of the new things that's happening, at least in a few states that I've seen, is that people are selling counterfeit like Xanax pills that have some fentanyl in it. That pill is obviously going to weigh a lot more than just fentanyl in the powder form, or pure fentanyl. Nobody uses pure fentanyl, but the mixture of powder or whatever. So 28 grams of pills, that is, depending on the weight of the pill itself, that could be just a handful of pills, or like between 30 and 60. I don't know the exact amount, depending on how much the pill would weigh. And so that is not a lot. For somebody who doesn't even know that they have fentanyl on their person, they could receive a life without parole sentences for trafficking, which means possession of 28 grams. And this is what he said. I'll wrap up after this. He said, and this, again, is the guy who supported justice reinvestment, very vocal about criminal justice reform. This is what he said this year. Quote, even if it did increase the numbers on incarceration, that's okay, because this is something we need to crack down on. And so that's just something I've been tracking. Thankfully, these two bills that I just mentioned, they died. But, in other states, there are bills that have been passing, and they've been sponsored or supported by people who have been traditional allies on criminal justice reform. One more, sorry, I said I was going to wrap up, but Maryland, the governor of Maryland this year introduced a bill on fentanyl, and he was like, this is something we need to crack down on. Just yesterday, he was like, there was this op-ed that we shouldn't follow Sessions and Trump on the way that they're addressing crime. Like there's, I just don't know why there's such a disconnect between this particular drug and other drug offenses. I don't know if they thought that people incarcerated for drug offenses were there for like marijuana. I know they don't think that, right? And so heroin is just like, people use heroin, people use cocaine, people use all sorts of drugs for all different kinds of reasons. This one isn't inherently more, like you're not more likely to be like a more dangerous criminal if you're using heroin. So I don't know why there's just this different rhetoric around it. I think just because people are dying. But yeah, in Maryland, he signed a bill, a Distribution of Opioids Resulting in Death Act this year, which allows prosecutors to seek an additional 10 years for dealers, who are oftentimes users themselves, who knowingly sell fentanyl and its analogs, which cause, overdoses or whatever. So it's just something to look at. It's something that I think conservatives need to do a better job of calling people out on. Because, if you're going to be strong advocates for criminal justice reform, that includes how we're dealing with this heroin crisis. And so we can't just let these people get off scotch-free because people are dying. I mean, we know these policies don't work. This isn't the best way to address this issue. And so we need to hold these public figures to account. Unfortunately, I think hysteria has kind of taken hold in a lot of these places, so it's harder to reach to let them hear you. But yeah, I think that's something that we need to be doing more of. So yes, I encourage criminal justice reform is still moving forward, but some people are trying to start taking steps back, especially when it comes to this issue.
Well, and I know in Maryland, kind of playing on the other end, nothing gets through that legislature without the blessing of Senate President Mike Miller and very heavily blue House and Senate. And I know in a lot of different areas, I work in civil asset forfeiture reform quite a bit. And a lot of our biggest opponents are individuals on the left that I work with quite a bit because sometimes they have some influence from police unions and everything like that. So it's very important from the right or the left that getting involved in your community and making phone calls in your jurisdiction. I was a staffer. I would deal with a lot of staffers. When they start getting phone calls and emails from inside their communities, they listen, and they listen good. And so a lot of these, I think some of these bills you see are from, big outputs from inside their communities. So continue to stay active, continue to stay involved, and that definitely helps. Something I want to touch on quickly, and I mean, it's something that's a huge issue, but before we kick it to the audience, is the idea of mental health in all of this. Rarely do you just have someone that is stand-up guy, clear head, focus, and now he's just getting strung out on heroin. It doesn't. There's something that always triggers this, either some sort of debilitating injury. I saw that quite a bit with veterans if they're coming back from Iraq. PTSD, tearing their ACL, they get addicted on things. Or there's some already pre-existing mental health condition. When you combine that with drug addiction, it definitely changes how people are, the approach to try to bring them back to some sort of rehabilitation standpoint. What has been your all's experience with dealing with mental health as kind of a binary diagnosis with drug addiction?
So we developed we've been actually prospective following 250 veterans who are all opioid users when we started working with them. And we we collect monthly data to try to get a sense of overdose risk behaviors and how that relates to sort of a biopsychosocial model. Changes in pain, physiology, PTSD, depression, right? Things like that, as well as social, life events, divorces, losing jobs, structural issues, right, too. Do you feel like you're stigmatized, right? And so we look at time and how these things, right? And really we do find, PTSD is a real big, and that doesn't have to be military. Most of the veterans we've interviewed, this is childhood trauma, right? This is growing up in poverty. This is having parents incarcerated, right? So there are all these things that really contribute to it. And I think a lot of them, they're, and I'm speaking right now particularly the veterans, but a lot of people, they have a lot of mental health needs. And if, the VA, we have a community sample. So only half of our participants are really people we work with are connected to the VA. A lot of people say very good things about the VA. A lot of the younger vets post 9/11 have some problems. If you have other than honorable discharge, there's paperwork and things like that. So the question is, where do you go to get services? If you're homeless, you can get sort of hooked up for sort of these wraparound services that work with the housing, work with the mental health, right? Work with all these challenges together. But I think it's more it's awareness that the overdose is not in isolation too. It's these things that, well, obviously contradicting all these different pills people can be on too, right? For a long time it was just strips of opioids and benzos, and now it's shifted to gabapentin and things like that. But I think, at least in New York, there's a lot of access for mental health services. But I think it's something that we need to think much more about. It's not just the drug that, proximal and distal in a sense, right? Most proximally, yes, you mix drugs, you have a period of abstinence, then you're at a higher risk for an overdose. More distal, you have periods of, potential combat, seeing people die, having your parents arrested, just poverty, the struggles of everyday life, I think, for many people. And it's not can't wave a magic wand, but it's much more we need to think about sort of this larger picture of, yes, drugs are one part of the problem, right? But there's a lot of things that really can exacerbate the negative health consequences. And people, there's a balancing act. People do need opioids, right? In some situations, right? And so, yeah, there've been prescribing practices shifts and things like that historically. So it's not an answer right there. I'll stop there, but yeah.
Yeah, I don't think we're going to solve mental health crisis today. We already checked off, obviously, opioids, but we'll get to mental health at some other point. With that, I'd like to ask some questions from the audience, and anyone has one. I think it's a small enough room, you sir, that you can just kind of shout. Yes, yeah.
Sure. Hi, Jim Parsons from the Institute of Justice. We've heard a lot about the issue of fentanyl, and obviously that is looking at the city department health numbers, it seems to be largely driving the increase in overdoses. What have the panelists seen in terms of getting out test kits or ways that people who are either selling drugs or buying drugs can actually know whether they're using, whether there's fentanyl in the drugs they're using? And the places that are providing ways that people can test the drugs they're using, and what would you recommend in terms of good practices there?
You guys are,
No, go ahead.
yeah, I mean, I know that I was meeting with a colleague in San Francisco. A lot of the some of the changes and programs are giving out fentanyl test kits. I know in New York, I believe HRC, harm reduction educators, we're about to purchase a bunch to give to people who we work, interact with. So I think it's a matter of getting the knowledge out there that they're there. Not always 100% accurate, pretty cheap still. So I think it's an important thing to deal with the fentanyl epidemic, as they say. I mean, and they, states across the country. In New York, it's just gone like up to like over half or something like that in terms of overdoses, fentanyl involved overdoses. So I think it's a very important thing.
Anyone else? Mark, would you want to say?
Yeah, we explored doing that in Baltimore and ran into a few challenges. And I think, I've left there, but I think the intention is still to move forward with some sort of distribution of those tests. And the challenges we ran into were both on with people we work with who are using drugs and also people who are selling drugs who, so we operate a needle exchange program that's mobile, and it's in neighborhoods where we have high rates of crime, poverty, drug use, all of these things. And it operates, frankly, right next to what are essentially open-air drug markets, because that's where the people we're trying to reach are. And they have good relationships with the people who are also on those corners selling drugs that let them do their job. They do, kind of leave them alone, and gave the feedback that distributing those tests would be seen as a threat to their business model. And then on the client side of our needle exchange clients, we really heard fentanyl's so ubiquitous anymore, I just assume it's in everything. And that's actually, and it is what we've seen over the last couple of years is, and I think you were getting to this, is that in the last quarter of 2016, it was the first time we saw that fentanyl-related overdose deaths outnumbered heroin-related overdose deaths. So we're talking about people who overdosed and died with just fentanyl in their system and not heroin. It used to be, flipped, where we'd see just a little bit more of the heroin-related deaths than the fentanyl-related deaths.
You, sir.
Hi. Hi, Steve Handelman of John Jay College. As I understand it, at the last count, some 41 states are now part of a coalition to sue prescription drug manufacturers. I wonder how whether the panelists see this as a help or a distraction to the cause of tackling opiates. It's to all of you, any of you.
Well, essentially, there's 41 states that are going to sue prescription drug companies on essentially prescription methods. And if it's
A help or
distraction or is it a help?
I mean, I'm probably the least qualified person on this panel to answer the question, but I'll take a stab at it. I think it's kind of a distraction. It's hard because as a libertarian, I'm like, I don't think there's one right way to do anything ever. I think that everything is individualized, and that's kind of how I approach criminal justice reform as well. But I think at least, so again, to go back to one of my main states I work in, Florida, they started cracking down on these pill mills and overprescribing. They started cracking down on it in 2011 in an attempt to limit the number of prescriptions that were given out. They were trying to close down some of these doctors were handing out like hundreds of pills to people with little accountability. I think that there's definitely room to kind of rein in that that behavior or have more education there. But as a result of this crackdown, at least in Florida, it not only did not help with the prescription drug epidemic that was there, it largely shifted a lot of people to using more dangerous drugs, heroin and fentanyl and things like that. And it's just been a disaster for the state. I mean, I think that, you have Baltimore numbers, which are obviously really much more devastating than statewide numbers of Florida, but I think there was over 800 people who overdosed and died from opioids in the last year, and that number has been ticking up since 2011, pill-related heroin and fentanyl. And I just don't know. I mean, again, I'm probably the least qualified person to talk about exactly, what could happen by limiting the number of prescriptions. But I think that just from my one experience in Florida, I saw that it didn't work. And they're trying again anyway. They're trying to limit the prescriptions to 3 days now for people who have opioids. And just I haven't seen that as a solution to addiction issues and overdose deaths. Could it be a solution to overprescribing? I don't know. But is it a solution to the opioid crisis and, overdose deaths? No, it actually exacerbates it as far as, just my own personal take.
I think we have time for one more question. Yeah.
So I'm doing work in Indiana on public defense reforms, and one of the offshoots that we've seen of this is extremely high volume of new cases that get filed that public defenders are responsible for to represent children or represent parents in cases that are being driven by the opioid epidemic. So in other words, double the number of child removals, double the number of cases that get filed. It's putting a huge strain on the public defender system as well as the courts and a number of other things. And I'm not seeing the statistics necessarily in some surrounding states that have had that huge uptick. And so I'm wondering if there are any programs that you have seen that have been effective that try to keep families together more, that avoid that intervention on a mandatory basis and those sort of mandatory policies for removal in the child welfare system. Because not only is it being criminalized on the adult side, those families are also then being torn apart by kids being removed.
And that just contributes to that cycle of trauma and mental health and addiction, I think, that we were talking about earlier. One model that, and putting on my addiction policy forum hat, which is only eight days old, so I probably miss some of the details here, but I believe there's a good program in Kentucky that intervenes with families who where a parent has a substance use disorder, may have some involvement with the criminal justice system, and really focuses on keeping families united. I mean, I think with the best interests of the children as the highest priority, but really trying to get that person into treatment, other services that they need, parenting support, things like that, to try to keep the family together if they can.
All right, with that, I think we're at the 12 o'clock mark. Thank you all for attending. Thank you to our panelists, and I think they'll be around for a couple minutes if you had another question.